Good morning, everyone, and welcome to day 4 of Kidney Action Week. I'm excited to be here today to kick off today's activities with our session, Gout and Kidney Disease. My name is Josie Cooper, and I serve as Executive Director of the Alliance for Gout Awareness. We are a nonprofit patient advocacy organization that works to raise awareness and understanding of gout, reduce stigma, and ultimately empower patients to successfully manage their disease. We are pleased to have the American Kidney Fund as part of our alliance, and I'm very happy to be here with you today. Now, before we continue, we do want to take a moment to recognize this session's sponsor. This session is made possible thanks to support from Horizon Therapeutics. We are incredibly grateful for their sponsorship of this educational session discussing the link between kidney disease and gout. I'm excited to be joined this morning by a great panel who will provide an overview of gout and its connection to chronic kidney disease, as well as bust some common myths about gout. First, we have Dr. Ellery Edwards. Dr. Edwards is a professor of medicine, Division of Rheumatology and Clinical Immunology, as well as program director and vice chairman of the Department of Medicine at the University of Florida in Gainesville. Dr. Edwards is also an active member of many professional organizations and has authored over 150 scientific articles, book chapters, and reviews on the topics of hyperuricemia, gout, and purine metabolism. We will also hear from a wonderful patient, Ellery Payton, as he shares his personal experiences living with chronic kidney disease and gout. Mr. Ellery Payton is a graduate of Howard University and holds a degree in Allied Health Sciences. He is a patient ambassador for the American Kidney Fund since 2004 and frequently uses his voice to tell people experiencing end-stage renal disease how they can live a full life if they manage their condition properly. Ellery learned his kidneys were failing in 2002, received a kidney transplant in 2003 that ultimately went through rejection, before ultimately receiving a perfect match from a living donor in 2012. We're excited to hear more about Ellery's story momentarily. And unfortunately, our third panelist, Ms. Theresa Caldron, was not able to join us today due to a family emergency, but we do thank her for her contributions to today's session. So one quick housekeeping item as we get started. Throughout our conversation today, we will be answering your questions. So please feel free to type your questions, your comments into the window next to or below the Facebook Live stream. And we'll try to get those answered, as many of those as possible. So without further ado, let's get started. So while we wait for our first questions to come in, we want to start with just a brief overview of gout and kidney disease. Dr. Edwards, can you give some background on how these two diseases are related?
Certainly. And I want to thank the AKF for inviting me to the Kidney Action Week. This is a wonderful venue for exchanging ideas about a very important connection between two chronic diseases. If I could have that first slide. The question of what is gout, it's at its basic understanding, it's an inflammatory arthritis. In fact, it's the most common inflammatory arthritis that there is. 4 times more common than rheumatoid arthritis or psoriatic arthritis, these diseases you see all the time on TV. But gout is much more common and can be every bit as destructive and problematic. It's, just apologize, far away from my screen. The gout is caused by an accumulation of uric acid in the body. Uric acid comes a little bit from the food we eat, not a great deal of the total percentage. The rest comes from breakdown of cells throughout the body, but especially in the bone marrow, leading to the formation of uric acid. People that get gout have elevated serum uric acid levels. A lot of times that comes from and most of the time it comes from the kidneys just not excreting enough uric acid. Occasionally, or rarely, it comes from too much uric acid being produced in the body. Hardly ever does it come from ingesting too much uric acid in the diet. Okay. The uric acid deposits around the joint and actually begins to form when we become adults. In men in teenage years, if you're prone genetically to have gout, you'll have your adult elevated level of uric acid around puberty, and over the next decades, you'll slowly accumulate. In women, they're protected throughout most of their adult life by the estrogens until menopause, in which time they'll begin to accumulate if they're genetically prone to get gout, and typically develop gout later in their life, in their 60s and 70s, as opposed to the 40s and 50s that men get it. The symptoms of gout are all well known to probably most people, and that is a severely painful joint, usually lower extremity. Cartoonists always make a point of singling out the great toe as the joint of target. In fact, it ultimately will be involved in most everybody that gets gout, but in the presenting phases of the disease, it can also be in the ankle, in the midfoot, in the knee, in women, more likely in the wrist and the hands. So joints that are out at the end of our extremities are what we call the cooler joints, and this has part of the factor of how joints accumulate. The various components, pain, most people with gout will register their pain on a 1 to 10 scale as either an 8, 9, or 10 when they have it. There's usually swelling associated with it and redness that surrounds it, and not just the joint. The redness can involve the whole area of the extremity and sometimes be misinterpreted by physicians, especially in the emergency department, as having an infection. Really and truly, one of the hallmarks of this disease is the suddenness that the pain comes on. Most people early on in their gout course have episodes that come on from a baseline of no pain when they go to bed at night, and they'll wake up and begin to feel the first twinges of it. And if not treated over the next 8 to 10 hours, they'll develop the full-blown symptoms. So very few conditions that we see in rheumatology have that kind of sudden onset and dramatic consequences. One of the other symptoms of gout that we lean heavily on is that it immobilizes the joint. When you have it, you simply cannot use it. If it's in the lower extremity, like the ankle and the midfoot or the great toe, you're generally not walking. If it's in the hand or wrist, you're not doing anything with that hand because of the exquisite tenderness that's there. Professionally, we call that condition allodynia. So just the slightest touch of anything that shouldn't hurt you at all is perceived as excruciatingly painful. Next slide. So what's the connection between kidneys and gout? There's this close connection, and it's being sorted out by the geneticists and epidemiology right now. We do know that about 1 in 10 people with chronic disease will develop gout. The flip side of that is that gout occurs in about 70%. That chronic kidney disease is at a level of stage 3A or worse, occurs in about 70% of patients with gout. So there's a very close relationship between these. We know that the kidney is very important in the ability to rid the body of uric acid. So any disease that affects the kidney and its filtration system will affect the serum uric acid level. Also within the kidney are the mechanisms, the pumps that take uric acid out of the bloodstream and put it into the urine. And some of these are very specific, and we've learned more and more about them over the past 10 years to the point that it's they're targets now of various medications that we're looking at. Important thing about the relationship between uric acid, gout, and kidney disease. It's been thought for a while that serum uric acid level elevations themselves, so if you have too much uric acid floating around in your serum, that might be toxic to the kidney. And there's been a number of studies in the past 5 years that have looked at that. And there is some data to suggest that that's true, but when the more detailed types of genetic studies have been done on these patients to look at the variants, we recognize now that uric acid itself is not causal, doesn't cause kidney disease. We do suspect that having gout, on the other hand, and forming crystals, and those crystals can form in the kidney, just as a predecessor to kidney stone disease or in the interstitium of the kidney, then they can become problematic and worsen both the kidney disease, and the reverse of that is that kidney disease can make gout much worse. Next slide. So there are a lot of complications of gout. People inappropriately think of gout as a disease that every now and then you get a very painful joint and you have to hobble around and be out of work for 5 or 10 days. But it's a progressive disease that can lead to incredible joint destruction and actually make people disabled because of the disease process itself. Part of that process is that uric acid gets laid down around soft tissues of the joints and of other pressure points in the body in what are called tophi. These are collections of uric acid and really are just demonstrating that the body has a very, very high level of uric acid and that it's getting deposited, not just causing occasional flares, but it's setting up for chronic symptoms. And so if these are located around the joints, they chew into the bone and cartilage and destroy it. So this is a very difficult thing. And the reason that we take gout so seriously, it's one thing to block the pain of the flares, but the most important aspect of gout is really to lower the uric acid so that this joint destruction over time doesn't occur. There is a chronic process of arthritis where you're not just having the flares, but you're having the joint aches and swelling all the time, very much like what rheumatoid arthritis would look like. Next slide. Kidney disease, again, I mentioned that there's several complications from gout. One is that you can develop kidney stones that are made of gout. A lot of other kidney stones, especially those made of calcium, might have uric acid at their core and might be the stimulus for developing the stone. So these are important aspects. We also know that high uric acid and crystal formation can cause disease elsewhere in the kidney, not in the collecting tubules, but within the interstitium of the kidney, and lead to a chronic form of urate nephropathy. Next. Next slide, please. Okay. So the treatments, the treatment for acute, painful flares of gout, we rely on anti-inflammatory therapies, particularly the non-steroidal anti-inflammatory drugs. I'll call those NSAIDs from now on. Colchicine is a time-honored drug that dates all the way back to Hippocrates, and it's still in use today, as well as corticosteroids, prednisone or Medrol, if you will. And these are drugs that are used when the symptoms of a gout flare occur. Clearly, there's problems with these, some of these drugs. If you have chronic kidney disease, your nephrologist is already telling you steer clear of the NSAIDs. Colchicine, you may or may not know, is also handled by the kidney, and with declining renal function, you have to be much more careful with colchicine as well. And for that reason, frequently we'll turn to steroids in people with significant kidney disease. But the important thing with those inflammatory or anti-inflammatory therapies is that you take them as soon as possible once you know that the flare is coming on. Once the flare has been there for 10, 12 hours, if you've had to wait that long to get a prescription from your doctor or for the pharmacy to open up in the morning time, you're way behind the 8 ball. And so we have a plan the American College of Rheumatology supports, which is a pill in the pocket. So whatever medication of this group you and your doctor decide are the best for the acute flare, you should have it immediately available to you so that when you get that painful awakening at 3 a.m. time, you're not going to have to wait around. You're going to go and start the medication right away. And if you do that, you can shorten these flares down from 7, 8, 10 days down to a day, as little as that. So that's the more important aspect rather than which of those you'd choose. The other aspects of treatment is just baseline keeping your body well hydrated. That helps flush the uric acid through the system. Other things we ask people to do is to think about their diet. These big restrictive diets where you can't eat red meat or shellfish or drink any beer don't have much utility, quite frankly. They don't replace the pharmacologic uric acid lowering therapies that all gout patients should be on. And they tend to make our patients kind of angry, so they don't come back and see us if we're telling them the things they can't have. Excesses of all those should be avoided. As far as a diet in general, our recommendation is something similar to a Mediterranean diet that's rich in fruits and nuts and grains, omega-3 fatty acids, so fish predominantly, and no high fructose corn syrup drinks or other foods. That's the best recommendation. A fair number of people with gout are obese, not all, of course. And if obesity is part of the problem, then a weight loss diet is really quite important as well. The most important part of treating gout is to be on a uric acid lowering agent. These include allopurinol, febuxostat, probenecid, pegloticase. All of these are ways of lowering the uric acid and have their own indications depending on the other diseases and how advanced the gout is. Next slide. So our treatment goals initially is to stop the pain of gout. That's the most important thing to the patient and is the most important thing to us when somebody presents in a flare. Long term, we need to reduce and keep the uric acid level down below 6.0 milligrams per deciliter. Everybody with gout should know what their last uric acid level is and should be helping their doctor find a way of getting it down to that level. At that level, uric acid crystals won't form, and eventually those that had been present in the body will resorb and go away and stop causing problems. And if you do that, over time, you will prevent the joint damage, as well as other organs, including the kidney, from being damaged. And it'll also improve the quality of life, lack of needing to miss work or playing with your kids or grandkids. It's gout is not curable per se, but it certainly could be managed. And I have a number of patients who haven't had a flare in 10 or 15 years are still on their uric acid lowering medications because that's a lifelong treatment. Next slide. Okay. Here's some takeaways, and I'm going to move closer to my screen just because I'm not seeing these well. It says, yeah.
Thanks so much, Dr. Edwards. I think we're going to pull that key takeaways slide back up. But I think, really what we wanted to share as sort of those key takeaways are a couple of things here. First, gout is a very common form of destructive arthritis. and it's linked to CKD. We know that the pain can be very debilitating, and it's increasingly common, when you have chronic kidney disease. 70% of people with gout have stage 3A CKD or worse, and 24% of people with stage 3A CKD or worse have gout. So there's a clear link there. And the presence of CKD, generally worsens, the course for gout, and limits sometimes the medications that can be prescribed to treat gout. So some of those medications, as Dr. Edwards mentioned, should be adjusted or avoided when a patient has kidney disease. But there still are treatment options. And so, we do want to encourage folks to be proactive in managing their gout, because this is a manageable condition. So with that, thank you so much, Dr. Edwards. As we mentioned earlier, Ellery is a fantastic advocate and dedicated to informing folks with kidney disease and related conditions. So as part of his advocacy work, he's worked on a great campaign called Faces of Gout, where he has shared a letter detailing his experiences with gout and with kidney failure. Ellery, thank you so much for joining us and being such a dedicated advocate.
Thank you. Thank you for having me. In reference to my experience with kidney disease, like the doctor explained, I literally woke up one morning, I felt like my foot was on fire. It was debilitating, as he mentioned. I couldn't go to work. I didn't know what was really wrong because at that time I hadn't been diagnosed with kidney disease or anything. In fact, I had the symptoms back and forth for maybe a year or two before I started experiencing major debilitating issues with my kidney. So I went for a really long time thinking that it was just pain. I had stubbed my toe or hit it or hurt it somehow, not knowing that it was actually gout. I mentioned it to a friend, thinking that I could get some advice. And I mentioned something about gout, and I was told that I had the old person's disease. So that kind of made me feel a little bit weird about it. And making a really long story short, I would say that, as I said, it went back and forth. Some instances are worse than others. I've had it in the bone beside my big toe, as he mentioned, towards my ankle. It's been all over the place sometimes. And when I finally figured out that kidney disease was related to why I was having these issues with gout, my doctor explained to me that the issue was my kidney wasn't cleaning out the dirty things, as she put it, as a normal kidney would do. So they started giving me the steroids of prednisone and some more of the pain medicines. But as my kidney started to deteriorate even more, I was getting it more frequently. And I had my first kidney transplant in 2003, as you mentioned. And it kind of went away for a minute, but it because I had so much trouble with that first kidney, I still had this problem with gout coming on and off, even throughout the first 8 to 10 years of me having that kidney. After my second transplant in 2012, I've not had any issues with gout at all. I still take the allopurinol daily. That's in my medicine regimen. So I've been living well without it for these last 9 years, since 2012. And I don't miss it at all. And that's been my experience with it after my second transplant. So it was directly related to the action on my kidney. So definitely the second kidney transplant was the key to what I needed to stop that.
Thanks so much, Ellery, for sharing your story. Now I'd like to turn to Q&A. So we'll start with a question for you, Dr. Edwards. How typical is the story that we just heard from Ellery?
Very typical. Transplant gout is a very difficult form of gout to treat. Patients with transplants, at least 25% of them, will develop gout, which is the same percent of the general population of people with chronic kidney disease. But the difference is that they'll develop it in a very short period of time, usually within a year or two, whereas people with chronic kidney disease usually have that smoldering lack of kidney function for years or decades before they get it. So this is a very accelerated process with transplant patients. Their uric acids tend to be much higher, and because of that, a little more difficult time getting on top of it with the conventional uric acid lowering therapies like allopurinol or febuxostat. I'm happy for Ellery that they were able to control that. I guess my question to you, Ellery, was that during the first transplant, was the hyperuricemia uric acid being treated when you had that transplant? Were they making an effort to get the uric acid level down after your transplant?
Initially, no, because I hadn't been told when I had my first transplant that even the kidneys were related to gout disease. My kidney disease was related to gout, rather. So I wasn't being treated until probably, I would say, year 2 of my first transplant, and then it was explained to me. Between that, I'd actually seen a podiatrist, and he mentioned something about having crystals in that area. So he actually took a biopsy of the area. He said he didn't find too many crystals in the sample that he took, but there were some. And at that point, when I was seeing him, I wasn't actually seeing a nephrologist at that point. So I knew that something was going on, but it hadn't been related to kidney disease at that point.
Yeah. Because that's a very important process with the transplants, is to make sure that the gout and the hyperuricemia, the elevated uric acid level, is under control before the time of the transplant, because otherwise it can lead to kidney injury. The reason that transplants are a problem is part of the immunosuppression that goes along with it. Back when cyclosporin was the primary drug that was being used to allow transplanted kidneys to stay functional, it was very, very common and very terrible disease. Since that time, different calcineurin inhibitors, tacrolimus and now sirolimus, are being used for organ transplants, and they have slightly less effect, but still needs to be watched. I think you brought up an excellent point too, Ellery, is that a lot of times the gout will be the development of gout will be a wake-up call for people to have their kidneys checked, because especially in a young, thin person like yourself, that's kidney disease is the primary risk factor for developing gout.
So, Dr. Edwards, just to follow up on that point then, so if you're a patient who, has had a first gout flare, would you recommend that then that patient goes and gets checked on their kidneys?
Yeah, that's actually part of the whole process. Aside from chronic kidney disease, there's a host of other comorbid chronic conditions that are associated with gout: hypertension, coronary artery disease, hyperlipidemia, so elevated cholesterols. All of these kind of go hand in hand with the metabolic syndrome, and gout is part of that neighborhood. And all of those things should be looked at and treated as part of the recognition that somebody has gout.
Thanks, Dr. Edwards. Ellery, I want to turn to a question for you. I know in the letter that we mentioned that you'd written as part of this AKF campaign, you mentioned your son. Can you talk a little bit about sort of the types of conversations that you have with your loved ones when you have a gout flare-up?
Well, it's initially I didn't know what to call it other than my foot was hurting. Upon realizing that my son was really young at the time. I adopted it when he was 2 weeks old. So I was actually starting to have issues with the gout before he was born. And I just kind of made it work. I've always been a person that just kind of moved through the pain, moved through, whatever it was that was going on, even when I was sick with having my initial symptoms for kidney disease. So as hard as it was in the morning getting dressed, even putting on a sock, trying to put on a sandal, because that's all you could wear, no shoes whatsoever. In fact, you really don't even want the wind to blow. That's what I say. And so the conversations that I have is that I try not to let that action stop what I need to do in the process, because even when having kidney disease, I've always tried to push through the illness. And while people know what's going on, and I'll mention I'm having one of those symptoms, or I have a soft lung, it's easy to see when when I was having those symptoms, or if something was going on. So I would always just say, I'm having one of those symptoms, I'm limping, and I just walk on the other side of my foot, literally. And I just kind of keep it moving. What people knew at the time when I found out that, okay, this is why I'm having these, this symptom, of my foot is hurting, or my ankle is hurting, or whatever. And now I know, I just have to figure out now how to help regulate the pain and do what I needed to do.
Thanks so much, Ellery. And I think that raises an important point of, we frequently hear from gout patients that they feel sort of isolated or like they can't talk about it. And being open about it and sort of sharing your experience in your day-to-day, I think can really help, make it seem less scary or less big.
Right.
That's certainly part of the problem of gout, is all the misconceptions that float around it, that this is somehow a self-inflicted disease, that you must have eaten too much or drank too much earlier in your life to have this disease, when in fact most of the predisposition to gout is genetic. That if somebody, particularly male in your family, has had it, then that's the risk factor. We're finding out now just how many genes control the disease. And in fact, diet, what you eat in your diet, has reasonably little to do with the development of gout. There is a big component that obesity itself, along with the genetics, is probably part of the risk factor. But this is a chronic disease, a chronic painful disease, and for people to make light of it, or to think that this is something that people deserve because they made bad lifestyle decisions previously, is just simply wrong and should be dispelled.
Absolutely. And I think it's certainly an important part of the work that all of our groups are working on. So to turn to just a couple of questions about gout management before we get into audience questions, Dr. Edwards, a question for you. What kinds of information or questions should patients with kidney disease come armed with to their appointment if they're experiencing some symptoms that might be associated with gout?
Right. Well, the diagnosis of gout can be established by one of two ways. If you see a rheumatologist, then frequently, and you see them during an acute flare of a joint, there's enough fluid in that joint that they can pull some off and look at the crystals, much like Ellery's doctors eventually did on that. And that's a confirmed diagnosis. The symptoms are usually so dramatic and typical in their location that just listening to the clinical story can certainly help you make a diagnosis, especially if there's a recurrent pattern of a severe flare that's followed by a period of where the joint isn't painful or tender at all, and then you have another flare in that or a different joint. So all of that's very typical. They should come with an open mind and listen to the recommendations. They should seek out good sources of information, both from Josie, your website, as well as the gouteducation.org website. The main issue that patients focus on is that they don't want to get a recurrence of these flares. They interrupt life. They're exceedingly painful. And to do that, ultimately, you're going to have to lower the uric acid. And you should know what the target is. You should know what your recent uric acid level is. And you should always be pushing to get that target, to get the uric acid down to that target of less than 6.
Thanks, Dr. Edwards.
People coming in and discussing it, it's important to know what your family history is of gout. I think that that's something that people, again, if they go back, they'll find an uncle or even their parents saying, yeah, I had that. I just don't like to discuss it too much. Again, this plays into that. mythology of gout being a self-inflicted disease. So people are a little embarrassed at having it, and that lack of communication actually is hurtful to the offspring.
Absolutely. I think that's a great point about coming in armed with a family history and asking those questions to your family if you don't already know the answers. Ellery, what kinds of things do you personally do to monitor your own uric acid levels?
Well, for me, I have a great relationship with my doctors. I was lucky enough to keep the main doctors rather, for my first transplant up to now. So I was never one of those patients that cried wolf easily. I ask a lot of questions. I mean, they all felt comfortable to even give me their cell phone numbers if something were to happen, because I had a lot of issues, like I mentioned, with my my first kidney. So, if I was having issues going on with the kidney, if I was having issues going on with something, I could call them, and most of the time they would meet me if I needed to go to the hospital emergency room or something like that. But what I try to do, and what I tell people all the time, is when I'm speaking, is to be aware of what's going on with your body, in your body. Once you know something has been identified, kind of learn from that, and don't be afraid to talk about it. Especially call your doctors, go to your doctors, see what's going on, and just be open about all of what's going on, all of what you're feeling, because there's no way that something can be identified if you're not sharing that information with especially your doctors, so that you can gain their trust, and they can know exactly what's going on, to put the pieces together to give you a diagnosis about what's going on, to treat it and fix it. So that's what I like to say. I try to keep a very open relationship with my doctors, just love them to death. And, I talk to them all the time, or whatever. If I have a question, I'll email or call them just to see, what's going on. Sometimes sometimes something is really going on that I need their advice on. So that's what I say. Just make sure you have a relationship with your doctors, a very good relationship, and that you're very open with them at all times.
I love that. I think that's an important point in sort of the self-advocacy, with your own healthcare provider. I guess I would ask a related question to you then, Dr. Edwards. Any advice to patients in terms of how to be an advocate for yourself with your healthcare provider?
Sure. Know what the right treatment approach is. And again, I've emphasized that a couple of times here, is that having anti-inflammatory therapy, whatever you and your physician decide, whether it's taking the non-steroidal anti-inflammatory drugs like naproxen or ibuprofen or one of the celecoxibs, and which one doesn't make a great deal of difference. It's just that you need it right then. You need it in full anti-inflammatory doses. And if you have chronic kidney disease, your physician and your nephrologist especially are going to say that's not a drug we want to use. Colchicine is another effective therapy, given usually as two tablets immediately, and one an hour later, and then 24 hours later you start taking them once a day or twice a day, depending on kidney function, is usually the one that approach that we go to in people with chronic kidney disease. And then steroids, usually in doses of 30 to 40 milligrams of prednisone initially, and then a taper over a week. All of those you should have available to you. But again, once the symptoms subside, the conversation should shift to, how do I keep this from happening again? And that has to do with uric acid lowering drugs. And once again, whether you're on allopurinol or febuxostat or pegloticase, would depend a lot on the stage of your gout or the stage of your kidney disease. And that's a discussion that you should have with your physician. The main point is that he should be as interested in getting your uric acid level to target as you are. And you need to keep pushing that until you are at that target.
Thanks, Dr. Edwards. Now, I know we've got a lot of great questions that have come into the audience, so I want to turn to some of those. Starting with a question for you, Ellery. What does it feel like when an attack is coming? Is there a way to tell early and plan ahead? Can you share a little bit about your experience there?
Yes, for me, I've had the gradual onset, and I've had where it just like hits overnight where you don't know. I mean, you're asleep, so you kind of feel that something is happening, but you're not fully aware of what's going on. So after I knew what was going on and what I needed to do, I keep the pills around like the doctor said. I take prednisone regularly, and I also take the allopurinol. So sometimes if I feel it coming on, I'll go ahead and I have, although the allopurinol is in my daily regimen of medicines, I'll sometimes, which I got cleared from my doctor, to take an extra dosage if I feel that coming on. And that has helped me to make whatever I was feeling go away. And actually, especially after my second transplant, even if I feel like something's going on, probably it's not happening, this is my own thing. If I feel that something is gradually coming on, I'll also double up on the allopurinol, just to make sure that it fights it. If there's anything going on that I'm feeling, if it's really that it's gout coming on or uric acid is building in my system, it's basically cleared out. So like you said, they catch it early, but if you're feeling that it's like you stumped your toe or something's coming, you haven't, but you just, that's the sign that you want to go in, and if you have the medicine, take it, or see if you can get in touch with your doctor or something right away.
Thanks, Ellery. I think that gets to the point Dr. Edwards made as well of treat it right away as you see the flare. A related question for you, Dr. Edwards, on the flare front, does gout only manifest itself in sort of the attack-like manner, or can it be chronic and everyday?
Yeah. Early on, most people have it as intermittent attacks. The average time between the first attack and the second attack is less than a year, sometimes somewhere around 11 months or so. And then as time marches on, if nothing is done to lower the uric acid, those attacks become more and more frequent, sometimes as frequent as every 3 weeks or so, 2 or 3 weeks. And that's usually after years of this process. So that's what most people think about when they think about gout, is this excruciatingly painful single joint involved. But over time, again, after 6, 7, 8 years, the joints that have been involved previously start to become chronically painful all the time, no reprieve from that. And we call this chronic gouty arthritis. It's the consequence that most people that are untreated will develop after a decade. And again, it mimics rheumatoid arthritis. A lot of people with chronic gout are misdiagnosed as having one of the other inflammatory arthritises, so that their joints are hurting all the time. They still have intermittent flares, but that's a well-recognized form of this disease.
And Dr. Edwards, then just to follow up on that, if you've gotten to that point, it's chronic, there's some disability there, what should you do?
Well, you should lower the uric acid. and the problem is that if all the time that you haven't been treating it since the very first flare and haven't been treating it with a uric acid lowering therapy, your body's continuing to deposit more and more uric acid around the joints, so that the burden of uric acid crystals becomes higher and higher, and just is harder and harder to dissolve all those crystals with traditional therapies like allopurinol or febuxostat. So if a person like that has chronic kidney disease, has lots of tophi and lots of joints involved, and you can't get them down to a very low level of uric acid with either allopurinol or febuxostat, then the biologic drug pegloticase, which is essentially an enzyme that goes in and cuts up uric acid. So it's a very rapid lowering of uric acid. It's an intravenous medication, but that is how we use this drug primarily, is to get rid of these large accumulations of uric acid around the joints. And then other more standard oral therapies like allopurinol or febuxostat can be used to maintain that level of normal target uric acid.
Thanks, Dr. Edwards. And I'll just note, I know we have touched on a lot of different types of medications, et cetera, during this program, but AKF, the Gout Education Society, us at the Alliance for Gout Awareness, we have a lot of information on this, that if you're looking for more information or you're trying to, write stuff down, we have more information available, and I'm sure that AKF can share that after this. A question for you, Ellery, and actually we've gotten a couple on this topic. When you've got a flare, ice, heat, what has worked for you? And Dr. Edwards, you might have thoughts on this too.
For me, I think ice has worked. Your foot is already hot, or that area is already hot. So I wasn't able to use in any of my past experiences heat. The ice does work. And actually it was through gout that I learned that I had an allergy to anything, codeine, Tylenol 3 and things like that. So that's the only thing that gout was helpful to me for, I guess. But taking the medicines that you have that I'll prescribe to you is something that helps. But I would say more so I stay towards the ice because, as I mentioned in my letter, literally for me at least, my foot, it feels like it's on fire and you want nothing to touch it. The sheet, the sock, the nothing. So my recommendation would be as much as you can take of ice.
Anything to add, Dr. Edwards?
No, there aren't very many studies, a couple of the use of ice in the acute flares, and most of them have shown a positive effect. My patients that have tried to put ice in baggies and lay them across the joints say they can't stand the pressure of the weight and the touch of the baggies, and so they don't use it. And I suggested that maybe if they just had a large enough pan that they could put some ice water in and just immerse their foot, that it might help. But really and truly, if you have this pill in the pocket kind of concept and you're treating the symptoms in the first 2 to 4 hours or up to 6 hours, things are going to get better really pretty quickly, and maybe you wouldn't need the ice, but ice rather than heat, if they can stand the pressure of the ice on top of the joint, then that's okay.
Okay. Thanks for that. Another question I want to address, because it's a common one that came in, gout and other comorbidities. Are your chances higher for getting gout if you have type 2 diabetes? Can you talk a little bit about the link between gout and other chronic diseases?
Yeah. Again, I mentioned before that there is a metabolic syndrome surrounding insulin resistance. So this is the precursor to developing type 2 diabetes. And all of these things include the fatty liver disease, the lipid abnormalities, the high cholesterol, and along with that, kidney disease and hypertension. These are the areas that kind of cluster together. We now know that uric acid isn't causal to kidney disease. Kidney disease can be a cause of gout in and of itself. In genetic studies, that group is a little bit different than the gout that's seen in patients with diabetes, with hypertension, with atherosclerotic heart disease and lipid abnormalities. That has a slightly different genetic feel to it, and that runs throughout the families as well. So what we know is that if gout is untreated and uric acid levels are high, it's much harder to treat a disease like diabetes. So that getting the diabetes under control makes the treatment of gout a lot easier. Getting the gout under control makes the treatment of diabetes a lot easier. So it's those kind of reciprocations occur throughout all those metabolic diseases, including hypertension and lipid abnormalities.
Excellent. Thanks so much, Dr. Edwards. There's a question that's come in that I want to address to both of you. What have you found, I guess, to be the most misunderstood thing about gout that you sort of want to correct?
I think I mentioned in my letter about the old person's disease. Um, I was, like maybe 30 something or another when I had my first round with it, which I didn't consider myself at that point. I'm older, but that it's, something that only old people catch for whatever reason, and that it's treatable, and also that you to know how to take care of it when you do have it, and what to do about it when you feel those symptoms. But for me, I would think it would be that it's not just an old person's disease. For me, I think.
Yeah. Yeah, that's very true. In fact, like I mentioned before, the usual time of onset for men is somewhere in their 40s and 50s, not, and women decidedly later. But yeah, and I think that the myths surrounding gout lead frequently to its undertreatment or the embarrassment of that people just simply not talking about it or seeking a doctor's input on it. I think the thing that I would want to dispel is the idea that the gout is simply a painful joint every now and then. It is much, much worse than that. And between all the time that the patient's feeling normal between flares, their disease is still progressing. They're still accumulating more and more uric acid crystals if they're not on a drug to lower uric acid, and their disease ultimately is going to get worse. So people have a flare and it gets better and they say, "Whew, that was wonderful. I hope I don't have that again," and think that the whole disease process is over. But they should be assured that it's not, that it's going to get worse over time if they don't do something about it. So seeking attention early is important.
That's a great point, Dr. Edwards, and leads me to another question that I think you partially answered here, but we've got a couple questions from patients, I think, that, around flare-ups and medication. If you haven't had a flare for a year or two, should you stay on your medication? What should you do?
Just like Ellery, it's lifetime. That is a very important aspect. The genetic and metabolic reasons that you have elevated uric acid in your body and form the crystals are going to be there, even after you've been on a drug like allopurinol for years and you've been pain-free. If you go off of the drug, that it's in those studies where people have been purposefully taken off of their drugs, usually the symptoms come back rather quickly within a year or so. And the accumulation of uric acid again speeds up and the whole process is there. So the bottom line of all guidelines, both in this country and internationally, is that once you get on a uric acid lowering therapy and you get the gout under control, is that you stay on the drug. There's very, very little toxicity from these drugs, especially after you've been on them for more than a month. So staying on them after years doesn't add anything to your risks of drug reactions.
Thanks, Dr. Edwards. I think that's extremely helpful to a lot of patients here. Another question I wanted to ask you, Ellery, that came in from the audience. Does your kidney doctor also treat your gout? Do you go to two doctors? What does that look like for you?
Yes, my kidney doctor mainly. Actually, I've kind of made my kidney doctor my main doctor, and my internal medicine doctor makes me come to see him. And I'm thinking, well, I only come to see you to get my once over, but everything that needs to be checked is checked by my nephrologist. So I let her or the team, they pretty much know about what's going on and where it's up or take me off with different medicines that will help the gout. So I've kind of in my own brain made my nephrologist my internal medicine, but I see my internal medicine doctor a couple of times a year, but not as often or speak to him as much as I talk to my nephrologist.
Great, thanks, Ellery. I think from our perspective as the Alliance for Gout Awareness, it's just most important to go to someone who has expertise in this, whether that's your nephrologist or a rheumatologist. Dr. Edwards, any thoughts there?
Yeah, interestingly, when they poll patients with gout as to who manages their gout, almost as many people have nephrologists managing it as they do rheumatologists. In truth, primary care physicians see the lion's share of gout patients. Unfortunately, fear of the drugs, lack of appreciation of the dire consequences of not treating the drug is frequently unappreciated by primary care physicians. And so when we see them in nephrology or rheumatology, they usually are a bit more advanced just from under treatment through that early stage of their disease.
Sure. And whatever type of provider you're going to, what tests should you ask for if you think you might have gout or you're trying to manage your gout?
Right. Certainly a uric acid level. You should know that if they're only measuring your uric acid at the time of flares, that it might be temporarily low. It's part of the inflammatory process of a gout flare. Affects a lot of things, and it even affects the kidneys to throw a lot more uric acid out in the urine, so that somebody that has a baseline uric acid of 9 or 10, when they are in the middle of an acute flare, it might be down as low as 7 or 7 or 6.5 even, and you might question whether this was gout at all because the uric acid level is close to normal. The idea there is to wait until you've been symptom-free for a couple of weeks before you get the uric acid level, and that would give you a more realistic baseline. But in addition to that, you certainly should get a lipid profile. You should get a chemistry panel with creatinine and estimated GFR on it. You should get a hemoglobin A1C just to see if they're in a pre-diabetic state. Those are the types of laboratory tests that are important.
Fantastic. Thanks, Dr. Edwards. So we have just a couple of moments left in our session today, but before we wrap up, I do want to give both of you the chance to share sort of any final thoughts. What's, I guess, the main takeaway that you'd like kidney patients to come away with about, working with their care team managing gout?
For me, being a kidney patient, and I was going to mention, I take personally 17 pills a day. So being able to group that in with my one doctor, although it may be initially prescribed by my internal medicine doctor, having them to know everybody communicates with everybody. I see all my doctors that I see in one spot, which is Washington Hospital Center. I don't go all over the place. To have everything centered in one area makes it that much more easier. And also say, since we're taking so much medicine, find out what medicines that you take could be attributing to the actual uric acid buildup, that you're taking every day to, help your kidney and keep your kidney working properly. But find out if there's anything else that you're taking, because we all take kind of different medicines, mostly the same, but there's some differences in the medicines that we take. But find out what could be attributing to your gout if that's something that you're taking within your medicine regimen.
Yeah, those are good points, Ellery. I would want people to know that gout is serious and it needs to be treated, especially those with chronic kidney disease. There's a lot of myth out there about the treatment and drugs that we use. The majority of physicians, in fact, think that allopurinol is toxic to the kidneys. That's simply wrong. There's never been a study that showed any toxicity. And so a lot of times when your nephrologist or rheumatologist will start you on a drug like allopurinol or febuxostat, somebody in your chain of medical treatment might think, oh, that's dangerous for them. Know the literature, have them learn the literature if they don't know it already, that we have to be cautious in adding medications to somebody with chronic kidney disease, but none of those treatments are taboo and they should be utilized.
Thank you so much, Dr. Edwards. And Dr. Edwards and Ellery, really thank you again for taking the time to join us today and for providing this really, really important information. We know there's so much to talk about when it comes to preventing kidney disease, and we're excited to bring both of you back for future chats in the future. So that will close out today's session. Thank you again to everyone at home and at work for joining in too, and thank you to our sponsor, Horizon Therapeutics. If you haven't already, please follow AKF on Facebook, send them your email through kidneyfund.org, and you'll be the first to know about other resources and events like this. Would encourage you to also check out Dr. Edwards' organization, the Gout Education Society. The link is up there, as well as our website, thegoutalliance.org. So please check out the rest of the agenda for the rest of Kidney Action Week. And we hope you will join the next session today, coming up at 12:30 Eastern, which is going to be focused on ADPKD and what you need to know there. So hopefully you'll be able to join. So after the conclusion of this session, you will see a link for a quick survey appear in green below the screen. Please take a few moments to fill that out and let us know how we did. And your feedback will be very useful as we plan future sessions. So with that, thank you everybody again, and have a wonderful day.